السلام عليكم ورحمة الله وبركاته. I am Dr. Muhammad Turki, lecturer of cardiothoracic surgery at Tanta University. Today we will talk about the chest tube. Our lecture will include the following items: pleura and mediastinum, definition of each of them, and definition of the chest tube, locations where we insert the chest tube, indications of chest tube insertion, and technique of chest tube insertion, and postoperative care, and alarming signs during the follow-up of the chest drains or chest tubes, and criteria for tube removal. Firstly, what is the pleura? It's an elastic serous membrane with a smooth lubricating surface divided into visceral and parietal pleurae, which merge at the lung hilum. Visceral pleura covers the lung parenchyma and extends between the lobes, keeping them separate from each other. Parietal pleura cover the inner surface of the thoracic cavity, diaphragm, and mediastinum. This diagram shows us how the visceral and parietal pleurae connected together as a hilum. For this diagram on the left side, the right lung is formed of 3 lobes, upper, middle, and lower lobe, and the left lung is formed of 2 lobes, the upper and lower lobes. The lingula is a part of the upper lobe and is its substitute to the middle lobe of the right side. For this picture, if you imagine that the lung is collapsed, so the visceral pleura covers the lung parenchyma completely and is inseparable from it, and the parietal pleura covers the inner thoracic cavity. Here is chest wall, lining the chest wall and covering the diaphragm and the mediastinum, and here at the hilum of the lung, the visceral and parietal pleurae merged together. What's the function of the pleura? It gives a flexibility to the organs of the thoracic cavity to move on each other. So the heart and lungs are allowed to expand, retract, and displace each other within the thorax. And it provides a smooth surface which reduces friction as the intrathoracic organs move against each other. So what is the pleural space? It's a closed potential space that exists between the visceral and parietal pleurae. It's about 0.01 mm in thickness. Normally it contains a thin layer of fluid, 10 to 20 milliliter in each side, and acts as a lubricant, as we mentioned before, between the pleural layers during respiration, so the lung can move smoothly on the thoracic wall and on the diaphragm and the mediastinum, and the lung lobes can move on each other without any friction. What's the normal resting pressure in the pleural space relative to the atmospheric pressure? Normally, the pressure varies by the timing of the respiratory cycle and the level within the thorax. Pressure at the mid-lung height and at rest is approximately -5 cm water. So it's at the mid-zone of the lung and at rest, not during exercise. The pressure in the pleural space is approximately -5 cm water. With deep inspiration, the pressure decreases to -25 to -35 cm water to allow air to enter inside from the atmosphere to the lung. Pressure is most negative at the apex and greatest at the base of the lung. What's the mediastinum? The mediastinum is the anatomic area located between the two lungs and the pleural cavities. It's divided into superior and inferior compartments by an arbitrary plane passing from the sternal angle anteriorly to the fourth thoracic vertebra posteriorly. The inferior mediastinum is subdivided into anterior, middle, and posterior part by the pericardium and its contents. In this diagram, it shows us how the mediastinum is subdivided. So, this is the mediastinum, this is the pericardial cavity, here is the clavicle, it's a lateral view, and here is the sternum, the manubrium sterni, the sternal body, and the xiphoid process. Here are the thoracic vertebrae. So, if we imagine an imaginary plane passing from the sternal angle, or the manubrio-sternal junction, or the angle of Lewis, all are the name of the same point. So the line passing from this point posteriorly to the thoracic vertebra number 4, the fourth thoracic vertebra, will divide the mediastinum into superior and inferior parts or compartments. The inferior mediastinum is further subdivided into anterior, middle, and posterior mediastinum by the pericardium and its contents. Okay, so here is the diaphragm, and here is the anterior mediastinum, the area anterior to the pericardium, and this is the middle mediastinum containing the pericardium and it contains the heart and part of the great vessels, and here is the posterior mediastinum behind the pericardial cavity. What is the pericardium? It's a double-walled fibroserous sac that ensheises the heart and great vessels. It's composed of an inelastic external layer known as the fibrous pericardium. It's fibrous, so it's inelastic. It's not expandable. And another mesothelial internal layer known as the serous pericardium. The serous pericardium is further subdivided into internal double layers surrounding a closed potential space known as the pericardial cavity. So, outside we have an inelastic external fibrous pericardium. Then we have a serous pericardium which has two layers. One of them is called the visceral pericardium, which covers the epicardium, or named as the epicardium, which covers the heart directly, and the other parietal serous pericardium, which causes lining of the fibrous pericardium. Between both layers of the serous pericardium, the visceral and the parietal layers, the area in between is called the pericardial cavity. The pericardial cavity contains a fluid in a normal heart. It's approximately 30 ml of transudate fluid which lies in the pericardial cavity. What's its function? Its function is to form a lubricant material so the heart can contract or beat smoothly and move smoothly inside the pericardium without any friction. Now, what is the chest tube? The chest tube is a tube that is inserted to drain a thoracic cavity, either the pleura or the mediastinum or the pericardium. Okay. The term chest tube is mostly used for tubes draining the pleural cavity, or the intercostal tube or tube thoracostomy. So, in general, chest tube is mostly used for tubes draining the pleural cavity, and at the time it's called intercostal tube or tube thoracostomy. But we can use it also to drain the mediastinum or the pericardial cavity. Locations of the chest tube. It's either pleural, as we mentioned before, or mediastinal. A pleural chest tube is located in the pleural cavity following thoracic surgery, including operations for the lung or the pleura, or any other surgeries that are accompanied by pleural opening of the pleural cavity. So you have to put a drain in the pleural space. It can be also located in the mediastinum following cardiac surgeries or any surgery accompanied with opening the mediastinum, like thymic surgery, which are surgeries performed on the thymus gland, which is present in the anterior mediastinum. Indications for chest tube. Both mediastinal and pericardial tubes are mostly inserted after surgeries involving the mediastinal structures and the heart, as we mentioned before. Pleural tubes are usually inserted either after surgeries involving the lung and the pleura, and also inserted primarily due to pleural disease such as pneumothorax, hemothorax, and any type of pleural effusion like chylothorax or empyema. Description of chest tube. The chest tube has different shapes and sizes, so it can match each intercostal space and each age of the patient. But in general, there are certain criteria for each chest tube, which include presence of multiple side holes, so it can drain the effusion or the pneumothorax or whatever from the tip of the tube and from the sides. So it should have more than one opening to allow drainage without obstruction. Usually the last side hole, as we see here, present at that radiopaque line. What's the importance of this radiopaque line? This radiopaque line will give us an idea about the position of the chest tube inside the thoracic cavity. So we can see the location of the chest tube, its position, is it in the intended position or no, if it's kinked, if it's present in abnormal location after its insertion, if it's inserted blindly in the primary pleural disease as we mentioned before, pneumothorax, hemothorax or whatever. So this radiopaque line gives us an idea about the position of the chest tube inside. Usually the last side hole present at that radiopaque line, so we can see it in the chest X-ray as interruption of the radiopaque line. So when we see the position of the chest tube in the chest X-ray, we just see the radiopaque line like this. So this is a tube and there is defect, then the radiopaque line complete its way. So this is the last side hole. What's the importance of it? This last side hole should be inside the thoracic cavity, the thoracic wall, I mean. So it should not be outside the thoracic wall. For example, if we inserted this one inside the patient, so for example, the chest wall should be here, and this part should be outside, and this part inside. So the last side wall should be inside the thoracic cavity, in a good distance from the chest wall. So it will not be outside, because if it's outside the chest wall, it will suck air inside the patient with inspiration, which is not true at all. Okay. This is the underwater seal system to which the chest tube coming from the patient is connected. This is called atrium. Its idea is that it's a closed system. Here, this tube is connected to the tube coming from the patient, and here is a collecting chambers here. So the fluid will start collection here, then here in the second chamber, then here to the third chamber. So this chamber will collect up to 2000 ml of fluid. And here is this underwater seal system. Okay, so we fill water here to this point, so the drainage, it works as a one-way valve, so the air can come outside here, but not in the reverse. So it comes from the patient to the outside. And this one is the venting of the air of the chest tube. So we have the underwater seal, and this is the venting of it. Okay, and we can connect it on a suction if we want to put the chest tube on a suction with a certain pressure or a certain negative suction. We can calculate here the amount of suctions that we would like to connect the patient to. Then we connect this tube to the outside sucker. to allow more drainage of effusion or drainage of pneumothorax if there is air leak. Technique of tube thoracostomy. Firstly, local anesthesia is applied at the site of the insertion, which is usually the fifth intercostal space at the mid-axillary line. We have what's called safety triangle or triangle of safety, which is bounded by the posterior border of the pectoralis major muscle and the anterior border of the latissimus dorsi muscle, and inferiorly it's bounded by the upper border of the sixth rib. It's laterally on the lateral chest wall. In this area, the muscle bulk is the least, and there's not much muscle bulk, so we can insert the chest tube at this area or this triangle. Mostly, it's the fifth intercostal space, mid-axillary line, is the ideal position for the chest tube insertion. So we give a local anesthesia at this point. We can do 1 to 2 centimeter incision over and parallel to the rib below. So if you will insert it on the fifth intercostal space, we make a 1 to 2 centimeter incision over and parallel to the sixth rib. Then a track is opened at the upper border of the rib, which is the sixth rib, I mean. So we are now in the fifth intercostal space. The tube is inserted using a large hemostat or tube trocar. Hemostat is an artery forceps by which we can catch the chest tube tip and insert it inside the pleural space and direct it upward or downward or anterior or posterior as we need, according to the collection, the position of collection, and according to the aim of the chest tube insertion. So if it's pneumothorax, it's better to direct it to the apex of the lung. If it's collection hemothorax or empyema or effusion, it's better to direct it downwards. Some chest tubes contain a trocar, which is a needle inside the chest tube itself. We can direct the chest tube using the trocar, which is rigid. So, but care should be taken because the trocar tip is very sharp and can easily injure the lung. As we mentioned, tube is directed to favorite place inside. After that, we have to take 2 sutures on each side of the chest tube. Okay, so we can close the wound around it and tie the chest tube, tie the sutures around the chest tube to fix it to the skin to avoid its slippage. Another one horizontal matrix suture is taken in the center of the wound and left untied for wound closure after tube removal. We call it as a stay suture, so it's just taken and not tied, because we tie it after removal of the chest tube. How can we manage the chest tube and what is the post-operative care of it? The following points are very important to be noticed while dealing with the patient who has a chest tube. Firstly, strictly keep the underwater seal. If the tube is not connected to the properly underwater seal, so the air will be sucked to the pleura and the lung will collapse because the intrathoracic pressure, as we mentioned, is negative in comparison to the atmospheric pressure. So with inspiration, the negative intrathoracic pressure becomes more negative and sucks the air inside the thoracic cavity and cause lung collapse. Never to be opened to air. The chest tube never to be opened to air at any point of its way from the chest wall to the underwater seal. Because the same idea, if the tube is opened to air anywhere along its course, also air will be sucked to the pleura and the lung will collapse. Number 3, never to raise the bottle up to the level of the patient's chest. Otherwise, the fluid in the chest tube or the fluid in the chest, in the bottle or the drain, the atrium, will come back to the patient's chest. Because the same idea, the negative intrathoracic pressure and the position, if the chest drain is the same level of the chest wall, so the fluid in the drain will come back to the patient's chest, which is not needed at all. If you would like to move the bottle from one side to one side, or during the patient movement from place to place, we can temporarily close it with a clamp, close the chest tube with a clamp, then after repositioning of the patient we can open it again and keep it at the level below the chest of the patient. Accurate calculation for the amount of drainage every day, and if it's post-operative, so in the first few hours. The accepted post-operative bleeding should be less than 100 ml per hour for the first few hours and decreasing significantly by time. Observation for the air leak and subcutaneous emphysema is a very important point. Usually in cardiac surgeries there must be no air leak from the tubes and no subcutaneous emphysema because the lung is not injured. So there is no source of injury, no source of air inside the chest. So after cardiac surgery, the tube drains should not give any air leak, just fluid drainage, like blood or serous or any collection after the operation. But in thoracic surgeries, there may be mild to moderate air leak in the tubes, but not subcutaneous emphysema. After thoracic surgery, because we manipulate in the lung, so there may be minute lung injuries that may cause mild to moderate air leak, which is managed by the chest tube and not leading to surgical emphysema, subcutaneous emphysema. Subcutaneous emphysema means that the air passes from the inside the pleural space to the subcutaneous area, and that happens if the source of air is very big, or there is a large injury to the lung, so the air passes more than the capacity of the chest tube to drain that air, so it passes also under the skin through the perivascular planes, okay, and cause what's called subcutaneous surgical emphysema. Slow motor suction may be applied to the chest tube. When slow motor suction is indicated, it's applied to the bottle rather than directly to the tube, as we saw in the previous photo of the atrium. Okay, rate of suction applied is 20 to 25 centimeter water for the mediastinal tubes, and may be increased to 30 to 40 centimeter water for the pleural tubes, because the pleural space contains more negative pressure than the mediastinal space, so we need a more suction to allow more drainage of the air and fluid from the pleural space. Observation of the tube patency should be done every day. How can we prevent its obstruction, the tube obstruction? By continuous slow motor suction after surgery, just after surgery, and keep it continuous slow motor suction, and frequent milking of the tube, so we don't allow any clots to obstruct the chest tube. Always confirm that the tube is in place. How can we confirm that? By marking the length of the tube from the chest wall, either by the number written on the tube or by marker if there is no scale on the chest tube. Most of the chest tube are graded or scaled, has a scale on it from 0 to 1, 2, 3, 4 up to 20 centimeters, and usually the scale is from the last side hole that should be on the radiopaque line, so we can know the distance of the chest tube inside the patient thoracic cavity, and at which distance is it enough or no. So in obese patient we should have a good distance from the last side hole outside the patient's chest wall, and so we have to follow up this mark every day. For example, if the grade is on 25, is on 20 or 15 or whatever, So every day when we do dressing to the patient, the site of the chest tube, we have to look at that number. Is it 15 or it's increasing or decreasing? If it's usually, if the chest tube is slipped outside, so the 15 becomes 14, 13 or 12, it's decreasing. So a little distance of the chest tube is inside the patient's chest. So care should be taken so the last side hole will not come outside the chest wall. If the tube is not scaled, at this moment we can do just marking on the chest tube with a marker at the level of the chest wall, and we have to follow if the marking point is at the same level or it's slipped away outside. During dressing of the chest tube, you have to be sure that there is no side hole outside the chest cavity, as we mentioned. We have to look circumferentially around the tube to see if there is a side hole outside the chest, especially if the tube is not scaled, because if it's scaled, we just know that the number is, if it's 15 or 12 or whatever, so the last side hole is 12 centimeters from this point inside the chest wall. If the tube is kept outside the chest, never push it inside because it's not sterile anymore. So what will we do is just to remove the chest tube outside if one of the side holes outside the chest wall. So we remove the chest tube completely and insert another new sterile chest tube under complete aseptic condition if we still need it. If we don't need it, or if the chest tube is slipped and it's the time to remove it, and accidentally it was slipped, we can just cover the position of the chest tube or tie the suture and do the chest X-ray and follow the patient. Tight closure of the wound after removal of the chest tube. On removal, we have to ensure that we don't keep the wound open by tightening the suture, the horizontal matrix stay suture that we did during the insertion of the chest tube, and we can tie it and do dressing for the chest tube for at least 6 to 12 hours. When you must activate alarms, there are certain signs that we have to activate alarm if we observe in the chest tube post-operatively. Firstly, if the bleeding is more than 100 ml per hour, we have to be very alert for that. And if the bleeding is more than 200 ml per hour for 3 successive hours, the patient must be explored to check the source of bleeding. If there is massive air leak with or without subcutaneous emphysema, we have to be alert also, because that means that there is a big source of air inside the chest, which is not normal. Even after thoracic or lung surgeries, it should be just mild to moderate air leak post-operative. The third one, if the drainage becomes turbid, that gives us an alarm that infection may start to occur to the effusion inside. The last one, if there is slippage of the chest tube outside the chest wall, and we have to deal as we mentioned before. Okay, if we still need the chest tube or it's still indicated to be inside the patient, we have to remove it completely. If it's slipped with one of the side holes outside, we have to complete it completely and insert another one under complete aseptic conditions. Criteria for tube removal. Firstly, totally inflated lung in the chest X-ray with no intra-collection of fluid in the chest X-ray. So that means that there is no pneumothorax, no residual collection, and there is no air leak in the tube, that means that the source of air is already stopped, so there is no air leak anymore, and the drainage from the tube is less than 200 ml per 24 hours in case of cardiac surgeries and less than 300 ml per 24 hours in thoracic surgeries. But this amount should be serous. It should not be blood, because if it's blood, 200 ml per 24 hours, it's a significant amount, so we don't remove the tube. Okay? If the amount is 200 ml of blood per 24 hours, it's a large amount of blood. So for these amounts or these numbers, it should be serous only. Okay? When the clear drainage from the tube is present, so just the tube collection contains no blood, and the fluid of the underwater seal is clear, so we don't need the tube anymore. So these are all of these are the criteria for removal of the chest tube, not one of them. Okay, so we should have all these items to remove the chest tube. Thank you.